Welcome back to another lecture in the course series of trigger point dry needling and manual trigger point therapy. My name is Jan Dammerholt, president of MyoPain Seminars, and in this lecture I hope to introduce you to some aspects of acute and chronic pain, particularly against the background of myofascial pain problems. We'll look at some outcome studies of treating myofascial pain both manually and with dry needling. Let's start with looking at acute pain, which, as you know, is often a result of injury to tissues, inflammatory processes, or from disease. It is usually immediately experienced and of short duration. We have a normal and expected response to acute injury. For example, when you cut your fingers when you're chopping onions in the kitchen, there is an expected response. You may scream, you definitely pull your finger back, you may shake your hand a little bit, you apply pressure to the wound till it stops bleeding, you may clean up your finger, you may put a band-aid on, and that's pretty much all there is to it. It will continue to hurt for a few days, especially when you use your hand, but it is a normal and expected response. Acute pain may be accompanied by anxiety or some emotional distress, but medical doctors and other clinicians can usually diagnose acute pain easily and treat it accordingly. If we compare acute to chronic, or perhaps better, persistent pain, there's a few variables that are the same and others are different. Acute pain is usually pain with a recent onset and it's well defined. Chronic or persistent pain may have a remote onset and many times patients don't really know what started the pain problem. Acute pain usually lasts a few days or weeks. Chronic or persistent pain may take months, years. The duration really is unknown and variable. Both acute and chronic pain may have variable intensity. In acute pain, the pain behaviors may be prominent when the pain is very severe. In chronic or persistent pain, the pain behaviors may be quite variable and dependent upon the position of the body, the weather, the time of day, the relationships with spouse or employer or supervisor, life in general, God, etc., etc. Looking at these two video clips can be quite painful and provokes a sensation of a severe pain experience. Both the tennis player and the soccer player do injure their ankle quite severely. While this may not be easy to watch, the point we try to make with these videos is that chronic pain is not the same as prolonged acute pain. In a future lecture, we will be talking more about peripheral and central sensitization, and that will bring the message home even stronger. I know this is hard to watch, so let's move on to the next slide. The numbers of people worldwide who suffer from chronic pain, in any variety of shape or form it may take, are staggering. In the United States alone, with a population of about 315 million people, almost a third of the population, 75 to 100 million people, are estimated to suffer from some chronic pain condition. Whether that's the daily chronic headache, low back pain, or pain from arthritis, pain from cancer, etc., etc. It is also estimated that 80% of nursing home residents in the United States may have substantial pain that is actually not recognized properly and therefore undertreated. The majority of pain patients have been in pain for 5 years or more. This is kind of a travesty, and one of the things we try to accomplish with our manual and dry needling courses is to make a significant change in how we handle patients with chronic pain conditions. We know that trigger points are common with acute and chronic pain, but the problem seems to be much more severe with the chronic pain. Patients looking at these staggeringly high numbers. Several years ago, I was asked to prepare an article about the role of physical therapy in an interdisciplinary pain management center. This was for a publication of the American Academy of Pain Management. And as I did the research for this article, I came across this line so many times that physical therapy is one of the pillars of pain management programs. Yet at the same time, it is crystal clear to me that very few physical therapists have received adequate training in clinical pain mechanisms and pain management strategies. During the last 5, 6, 7 years, this may have changed a little bit as there is much more knowledge about pain sciences, and slowly but steadily the pain sciences are being integrated in our education. In an older study published in Physical Therapy in 1991, 96% of physical therapists admitted not liking management of chronic pain patients. In other words, maybe only about 4% of physical therapists do enjoy working with chronic pain patients. That doesn't bode very well. We think that by incorporating manual trigger point therapy and dry needling, chronic pain patients are much less of a challenge because we can actually offer solutions. Considering how few physical therapists have joined the APTA Pain Management Special Interest Group or are members of the American Academy of Pain Management, it still appears that physical therapists have very little interest in dealing with patients with persistent pain. When we recently checked the APTA Pain Management Special Interest Group membership, less than 400 out of a total of 85,000 APTA members had joined the Special Interest Group. That is less than 0.4%. The American Academy of Pain Management has less than 100 identifiable physical therapy members out of a total membership of approximately 6,000 members, which equates to less than 1.6%. In the current edition of the Guide to Physical Therapist Practice, a publication of the American Physical Therapy Association, limited guidance is offered in determining the best physical therapy approach for persons with chronic pain conditions. The guide does not really recognize chronic pain as a specific disease, diagnosis, or even as a musculoskeletal pattern. At this point, it is not clear whether the new edition of the Guide to Physical Therapist Practice will address chronic pain conditions more effectively. When we try to answer the question, what is pain? One has to be very suspicious of people who think they know the answer. Because simple, single construct models of pain have very limited usefulness as theoretical foundations for the clinical intervention. If pain is made too simple, it is probably poorly understood. There are many common myths about chronic or persistent pain, both in the media but also in the professional world. Clinicians often may suggest that they know what pain is, that we know the biological or the psychological basis of pain. We may state that pain is in the body or in the mind. We may state that pain has either a sensory or affective and or a cognitive component. Some people say pain is psychogenic, while others say that pain is not psychogenic. Many patients report that the doctor said that pain is all in your head. Some people claim that pain without discernible organic basis is functional or only psychological. Especially in the functional capacity evaluation world, people have come up with so-called objective tests to identify non-organic pain. And lastly, the beliefs are that pain patients frequently malinger, although there's no evidence of that, and that opioids always cause addiction. Another important aspect to understand is that chronic pain is multidimensional. At the most basic level, when nociceptive information is transmitted from the periphery to the dorsal horn, the individual does not necessarily perceive pain. The nociceptive input needs to be of a high frequency and intensity to breach the threshold for the nociceptive information to be transmitted through ascending pathways to the cortex eventually to have a perception of pain. Having a perception of pain does not mean necessarily that an individual is suffering. But if the nociceptive input continues, as is the case in myofascial pain, fairly quickly an individual may start suffering from pain, which consequently may lead to certain pain behaviors and avoidance in meeting with friends, colleagues. In other words, there could be a change in the interaction with the environment. This model, first described by John Loser, is important to understand. Not all pain patients suffer, display pain behaviors, and have difficulty interacting with the environment. We already said that close to a third of Americans suffer from chronic pain conditions, yet many of these individuals go to work every day. They may be suffering to some extent, but they can function perfectly well. Although for some, it may be obvious that nociception is not the same of pain. In our daily use of the language of nociception and pain, many clinicians equate nociception with pain. We tell our patients that we have pain sensors and pain signals travel through the spinal cord and reach our brain, but in fact that is incorrect. We have nociceptive input, for example from myofascial trigger points, that reach the dorsal horn, and when the intensity and frequency of this nociceptive input is strong enough, it may eventually lead to an experience and a perception of pain. But nociception, by definition, is not the same as pain, and I think we need to be careful in how we explain pain mechanisms to patients and not confuse the terms nociception and pain. We have mentioned the neuromatrix by Ron Melzack before. And we've explained that Melzack identified inputs to the body self neuromatrix, a processing plant so to speak, which results eventually in different outputs from the neuromatrix. On the input side, Melzack clearly identified trigger points, but also looked at visceral input, visual, vestibular and other sensory input, cutaneous input, but also more cognitive evaluative inputs like basic input from the brain, attention, expectations, anxiety, depression, cultural learning, past experiences, personality variables, and at the motivational affective side, Melzack clearly sees a role for the HPA axis, the immune system, cytokines, endogenous opiates, the limbic system, etc. Because there are so many possible input systems and each individual will process all this input in his or her own unique way, there are no two patients with chronic pain the same. The outputs are totally different. Some people may have more of a pain perception, other people may express their pain issues more in their coping strategies or in their voluntary or involuntary action patterns. And other people may exhibit high cortisol levels or cytokine levels that are off or low endorphins, etc. The neuromatrix by Ron Melzack is a great model to understand why no two patients are the same. In December 2013, I mentioned on a website, somasimple.com, that Ron Melzack recognizes trigger points and incorporated them into his neuromatrix as a potential musculoskeletal input. I think this is an important point to make. But that statement, although based on the previous slide, was met with some resistance. One of the moderators of this website immediately replied, well, he took them out in this new version a few years ago. This individual provided the link to the version of the neuromatrix depicted in this slide. And indeed, Melzek no longer mentions myofascial trigger points as a separate input. Instead, it seems to be summarized by musculoskeletal inputs. In the same slide, Melzek no longer mentions depression. He no longer mentions cytokines. So, in other words, based on this picture, can we conclude that Melzek no longer believes that myofascial trigger points are important in the neuromatrix? Well, interestingly, when you read the article where this picture was published, in the body of the text, he clearly talks about myofascial trigger points, and he talks about cytokines, although they're not listed specifically by name in the diagram. Here you see the two versions of Melzek neuromatrix depicted next to each other. You see it on the left, Melzek includes trigger points, cytokines, depression, and on the version on the right, he no longer includes depression, he no longer includes trigger points, but seems to summarize it as musculoskeletal input, and he no longer mentions cytokines or even endogenous opioids. So did Melzek realize his error, as was suggested on the Soma Simple website? When I pointed out on the website how surprised I was that the individual apparently only looked at the pictures and had not read the actual article, the person replied, well, I guess one would have to ask Melzek what he thinks trigger points represent then. Well, I decided to contact Dr. Melzek and inform him of this exchange on somasimple.com. I explained that because of the difference in the two pictures, some physical therapists seem to think that Dr. Melzek no longer believes that trigger points are an important input system into the neuromatrix. On Christmas Day 2013, I sent him this email, and a few weeks later Dr. Melzek replied. And he stated, trigger points are a fact. I decided to trim the legend in the figure because the first version was too wordy. He agreed with me that if someone had read the actual article, there should have been no confusion whatsoever. Another way to look at pain is the opinion by McCaffrey and Beep. Whatever the experiencing person says it is, existing whenever he says it does. In other words, they advocate do not question your patient when they say they have pain. Whether it's a chronic pain condition or an acute pain condition, do not question. It is whatever the person says it is. The images on this website are borrowed from a website called painexhibit.org, which features artworks from patients in pain. It is an interesting website that deserves your attention and possible support. As we are discussing different aspects of pain, it is also important to know that pain is always a perception. When I look at this picture, what I see may be quite different than what my dog sees. In other words, just as this girl tries to draw the nude model, she has different perceptions of what that should look like. Pain, by definition, is always, always, always a perception that cannot be argued about and should not be argued about. When a patient presents with pain, as a clinician, you have no choice but to believe the patient and figure out what the mechanisms are, the contributing factors, the perpetuating factors, etc. Alan Basbaum, a prominent researcher at the University of California in San Francisco, reiterated the point we just tried to make. Pain is not just a stimulus that is transmitted over specific pathways, but rather a complex perception. There you have it. A complex perception, the nature of which depends not only on the intensity of the stimulus, but on the situation in which it is experienced. Lorimer Moseley came up with a different perspective about pain. He stated in 2003 in Manual Therapy that pain is produced by the brain when it perceives that danger to body tissue exists and that action is required. I must admit that I have always had difficulty with the phrase that pain is produced by the brain, although it is a common line in current pain sciences amongst physical therapists all over the world. When we say that one part of the body, an organ, in this case the brain, has superior qualities over the human individual who owns that brain, so to speak, it suggests some kind of return to dualistic thought processes in a postmodern world. So I was very pleased to see that in February 2014, Moseley reported on his website bodyandmind.org that I have slowly come to understand that pain is not an emergent property of the nervous system, but of the human. I don't believe that many folks in the pain sciences world have picked up on that or have given it much thought. In my opinion, pain is not produced by the brain. Pain is produced by the human being based on their input systems, their processing part of the neuromatrix. So when we take this all back to myofascial trigger points, we have already seen that trigger points feature motor characteristics, such as disturbed motor function, weakness as a result of inhibition, stiffness, and restricted range of motion. Trigger points also feature certain autonomic characteristics, such as vasoconstriction, vasodilatation, lacrimation working in the head-neck area, piloerection, and others. We don't know much about the autonomic symptoms, as very little research has been conducted in this field. Since this is an introductory lecture to pain sciences, let's focus on the sensory aspects of trigger points to include local tenderness, referral of pain to a distant site, and peripheral and central sensitization. Central nervous system changes, including sensitization and neuroplastic changes, are not unique to myofascial pain. But myofascial pain also features these changes, including hypersensitivity, allodynia, and secondary hyperalgesia or referred pain. We will discuss this in more detail in the sensitization lecture in a future course. Approximately 50 years ago, there was an increased awareness that muscles do feature many nociceptors. And slowly but steadily, the role of muscle nociceptors has been recognized. And indeed, muscles have glutamate receptors, such as the AMPA and NMDA receptor, serotonin receptors, prostaglandin receptors, adenosine receptors, purinergic and phenyloid receptors, etc. And it is a fact that muscle tenderness is mainly due to the sensitization of all these muscle nociceptors. For example, by an acidic pH, by prostaglandins, bradykinin or serotonin, etc. This continuous nociceptor sensitization or activation can lead to neuroplastic changes in the peripheral and central nervous systems, and that is a hallmark in the transition from acute to chronic pain. When we look specifically at referred pain, it is known that nociceptive impulses entering the spinal cord can spread upward and downward, or usually they go downwards, over 7 to 10 spinal segments. This includes the activation of dormant synapses and morphologic changes that are reinforced with persistent stimulation. Roland Stott, a researcher in Florida, has identified that muscle input, particularly nociceptive input from muscles, is a critical component to continue the central sensitization. We believe that myofascial trigger points provide exactly that kind of persistent nociceptive input. Clinically, we can identify myofascial pain by looking for discrete bands of hardness in muscle, which we typically refer to as a taut band, which is a contracture. When we palpate the taut band, you should be able to find regions of severe tenderness within the taut bands. When you press on these regions, you often can cause referred pain to a distant region. And these symptoms are very common in problems of muscular pain, headaches, chronic whiplash, viscerosomatic pain, pelvic floor pain syndromes, nerve entrapments, radiculopathy-like symptoms, amongst many others. There is no question that musculoskeletal pain research is falling a little bit behind other silos of knowledge, silos of study of aspects of chronic pain. Researchers have focused for a long time on the role of cytokines or neurotrophins. Glia cells have been a focus of much of attention by many researchers, particularly in Colorado. And glia cells are much more than just supporting cells of the nervous system. They play a critical role in many, if not all, pain syndromes. There are researchers looking at nerve injury models, while others concerned more about the central or peripheral nervous system. And musculoskeletal pain is fairly new on the block. But it is important that we need to get away from too much linear thinking without looking at all the aspects of pain, including musculoskeletal pain. It is time to create a big picture integration to truly understand chronic pain conditions. Only by integrating all the different models of pain research are we really reflecting the intention of the neuromatrix. Musculoskeletal pain has to become an integral and equal partner in the overall pain research efforts. Back to trigger points, we do know by now that to identify trigger points you need to find the taut band, elicit tenderness and maybe referred pain. In the physical examination you will find usually restricted range of motion and weakness, and very important, which is more of a task for physicians, is to conduct the appropriate laboratory test for comorbid disease. In addition to manual therapy to inactivate the trigger point and restore normal muscle function, we could consider trigger point needling or injections to inactivate the trigger point. And on top of that, it is always important to look at precipitating and perpetuating factors, which can be mechanical, medical, and psychological. In summary, at MyoPain seminars we believe that there is more than sufficient research to support the notion that active myofascial trigger point function as dynamic foci of peripheral nociception that can initiate, accentuate, and maintain central sensitization. The continuous nociceptive input from trigger points can increase the excitability of dorsal horn neurons, leading to allodynia, hyperalgesia, and open ineffective synapses, resulting in new receptor fields, sensitization, and a referral of pain or secondary hyperalgesia. So is there any evidence that manual trigger point therapy and dry needling actually works? What about clinical outcomes? So let's take a few minutes and look at a few clinical outcome studies. Here we see a paper published in Clinical Chiropractic in 2010 of patellofemoral pain syndrome managed by compression of trigger points located in the peripatellar and retropatellar region. The researchers found that manual trigger point therapy was effective in the short and medium term at reducing symptoms of patellofemoral syndrome for up to 6 months. You can see in this slide that the authors use the term ischemic compression. This is a bit of an outdated term. In the 1999 Travell and Simons book, they discarded the term ischemic compression and replaced it with trigger point compression. As you know by now, trigger points are already ischemic, hypoxic, and there's no point in creating more ischemia to solve the problem. In a different paper from the same authors, they suggested that myofascial trigger point therapy, manual therapy, again using ischemic compression, though they probably did not cause ischemia, on trigger points in shoulder muscles may reduce the symptoms of patients experience chronic shoulder pain. There were several other studies that have confirmed this, and as we will see later. Another paper by the same primary author looked at manual trigger point therapy for chronic carpal tunnel syndrome. And they found that manual compression techniques along the length of the biceps muscle at the bicipital aponeurosis, but also including the pronated teres and the subscapularis muscles, reduce the symptoms associated with carpal tunnel syndrome for up to 6 months. I think it's time that physicians and other clinicians who deal with patients with chronic carpal tunnel syndrome will start incorporating myofascial trigger point therapy. Rob Grieve and his team, a physical therapist and PhD in England, looked at the immediate effect of soleus trigger point pressure release on restricted ankle joint dorsiflexion. And what they found that manual trigger point therapy resulted in an immediate significant improvement in ankle range of motion after only one intervention of trigger point pressure release on not even active but just on latent soleus trigger points. This is a strong statement published in the Journal of Bodywork and Movement Therapies in 2011 that manual trigger point is worth considering. There are many different ways to provide manual trigger point therapy. In this interesting paper, the researchers looked at the effects of traditional Thai massage on trigger points with a focus on heart rate variability and other stress-related parameters. And what they found that only 30 minutes of traditional Thai massage in the prone position was very effective in increasing the cardiac parasympathetic activity, reducing sympathetic activity, and reducing pain and stress in patients with back pain associated with trigger points. Again, traditional Thai massage, like other forms of manual trigger point therapy, are non-pharmacological interventions with no particular side effects, other than perhaps some soreness following the treatment. There's also some research about what patients can do themselves to treat their trigger points. In this paper by Gulick and colleagues, also published in the Journal of Bodywork and Movement Therapies, they found that a protocol of 6 repetitions of 30 seconds compression using the so-called back knobber every other day for a week was effective in reducing the trigger point irritability of different trigger points. Again, in this paper, they also used the term ischemic pressure, ischemic compression, which is unlikely to have occurred and certainly is not desirable. A team of clinicians in California under the leadership of Rodney Anderson, a urologist, David Weiss, a psychologist, and Timothy Sawyer, a physical therapist, have applied manual trigger point therapy to mostly patients with chronic pelvic pain. They have worked a lot with patients who have prostatidynia or pain in the prostate, but they also see female patients. In this slide, you see a device that they developed to manually treat internal myofascial trigger points. And they've concluded through many studies, and this is one of many, that a multimodal protocol using an internal pelvic therapeutic wand is actually a safe, viable treatment options in some patients with chronic pelvic pain. Here's another paper by Rob Grieve and colleagues from England. This is a case series report in which they show that multimodal trigger point therapy consists of manual trigger point techniques can be very helpful for select patients with subacute or chronic calf pain. They will use this information to do more rigorous research in this region. Dr. Braun from the Netherlands and colleagues conducted a study of the treatment of myofascial trigger points in patients with chronic shoulder pain. This was a manual treatment protocol. Subjects in the intervention group received comprehensive treatments once a week consisting of manual compression of trigger points, stretching of muscles, intermittent cold application with stretching, home exercises with stretching and relaxation, where needed, ergonomic recommendations, and posture training as needed. The researchers found that a 12-week comprehensive treatment of trigger points in the shoulder muscles of these chronic shoulder pain patients reduced the number of muscles with active trigger points and was found to be effective in reducing the symptoms and improving shoulder functions overall. At MyoPain seminars, our dry needling courses focus primarily on trigger point dry needling, although we do include other clinical entities such as tendinopathy. The two studies on this page both deal with tendinopathy. The top paper, reported in the Journal of Orthopedic and Sports Physical Therapy, looked at two runners with the proximal hamstrings tendinopathy who were treated with a combination of eccentric loading, lumbopelvic stabilization exercises, and dry needling of trigger points. And this provided short and long-term benefits in pain reduction and function. The second paper, published in the Journal of Chiropractic Medicine in 2013, reports on dry needling directly of the tendon. They used ultrasound-guided dry needling to treat a supraspinatus tendinopathy with great results. Dry needling can indeed be used to treat tendinopathies. Here are two more papers that show that the results of tendinopathy dry needling can be quite encouraging. The top paper used dry needling as a method of tendinopathy treatment, while the bottom paper by James et al. Used ultrasound-guided dry needling and blood injections from patella tendinosis. And the authors reported great results with both treatment protocols. The paper we see here is one of the most interesting papers of the effectiveness of trigger point dry needling. We believe that this is the only double-blind, placebo-controlled dry needling paper currently in the literature. It was published by Orlando Mayoral and colleagues from Toledo, Spain in 2013. What did they do? In a group of 40 patients who were scheduled for a total knee arthroplasty, in other words, a total knee replacement, they divided the patients in three groups: one that got true dry needling, one that got sham dry needling, and a control group. They examined the tensor fascia latae, the adductors, the quadriceps, hamstrings, gastrocnemius, and popliteus muscle. And what's interesting about this study, that as soon as the patients were anesthetized right before the surgery, they were actually, half the people were treated, the ones in the dry needling group, with dry needling of the trigger points that had been identified before. Since the patients were anesthetized, they were totally blinded to the particular intervention they got. The other patients who were in the total knee replacement group received sham dry needling, and the control group was not treated with surgery at all. Mayoral and colleagues reported amazing results, where it took 6 months to reach a 20% level of pain for the control group and for the group that received sham needling or no needling at all. The group that received dry needling right before the total knee replacement reached a level of 20% after 1 month following the surgery, compared to 6 months for the control groups. We believe again that this is the only true double-blind controlled needling study currently available. In this review paper published in Cephalalgia, the researchers found only 3 studies that met the criteria that they were looking for. And the researchers were looking for the effect of dry needling on chronic tension-type headaches or cervicogenic headaches that met the International Classification of Headache diagnosis. What they found that in these 3 studies, each study showed improvement in outcomes, which, according to the authors, supported the use of dry needling in conjunction with other treatments for management of headaches. Much work still needs to be done to prove that dry needling is actually an effective therapeutic modality. In the paper by Cummings, reported here, published in 2001, they concluded that wet needling or injection therapy is not therapeutically superior to dry needling. They looked at 23 out of 61 articles that met the criteria. They concluded that dry needling of trigger points appeared to be effective, but they did not find any evidence that needling therapies have efficacy beyond placebo, and they couldn't find any research that supported that. So their conclusion was we need better research. In the second paper by Tuff and colleagues, they included 7 randomized controlled studies of acupuncture and dry needling for the management of trigger points. Evidence from one of the studies suggested that direct needling was effective in reducing pain compared to no intervention. However, 2 studies provided contradictory results when comparing dry needling of trigger points versus needling anywhere else in the muscle. The evidence from 4 other studies failed to show that dry needling directly into a trigger point was superior to various non-penetrating sham interventions. Tuff and colleagues mentioned significant methodological limitations of original studies included in the review. Firstly, although myofascial trigger points seem to have been identified carefully in most studies, it was not clear that they were the sole cause of pain. Secondly, the sample sizes of the 7 studies were generally small, which raises the possibility of a type 2 error, where the likelihood of a study producing a false negative result is increased. Thirdly, treatment intervention varied considerably in the location of needle placement, the depth of insertion, individual treatment times, and the overall number of treatment sessions. They concluded unless evidence of the possible mechanism of action of needling is available, or until different interventions have been compared directly, there is no logical basis for choosing the optimal intervention. More research is clearly needed. Another more recent paper published in the Journal of Body Work and Movement Therapies in 2014 looked at 5 randomized controlled studies that compared dry needling to lidocaine injections and one compared it to sham laser. The research concluded that there is no significant difference between dry needling and the lidocaine, as both improved. The patterns they saw was that injections improved pain immediately after treatment, and dry needling showed improvement in 3 to 6 months. There are a few issues with this paper, particularly since they included studies of lidocaine injections that were very questionable. And that's a problem with most meta-analysis, that if the researchers do not look at the true quality of the papers they include and only look whether they meet certain bias criteria, it is possible to come up with conclusions that are not really supported by the articles that were included in the paper. In 2005, Furlan and colleagues looked at dry needling and acupuncture for low back pain in a Cochrane review. Throughout the paper, they clearly separated acupuncture from dry needling and did not merge them together as some acupuncturists have later published. The conclusions of the Cochrane collaboration in 2005 was that dry needling appears to be a useful adjunct to other therapies for chronic low back pain. We have already mentioned the paper by Lucas and colleagues from Australia, who found that dry needling of latent trigger points combined with stretching restores normal muscle activation patterns in the shoulder. This is an important paper, and this paper was later repeated with loaded conditions versus unloaded conditions first reported in 2004. Di Lorenzo and colleagues from Italy conducted a beautiful study published in the Journal of Musculoskeletal Pain in 2004. In their study of the treatment of hemiparetic shoulder pain with dry needling, they only used one variable, and that variable happened to be dry needling. So over 100 patients with shoulder pain after a cerebral vascular incident were divided into 2 groups. One group received dry needling in addition to the normal rehabilitation program, while the other group did not get any dry needling. The group that got dry needling reported less severe, less frequent pain, leading to a reduction in their analgesic medications. They restored their normal sleep patterns, and they were actually looking forward to continuing with the rehabilitation program. I believe that this is one of the very few papers in the literature that had only one variable of dry needling. It's a great paper in support of dry needling. From Turkey, it was this interesting paper published in 2012 about the effect of dry needling in the treatment of myofascial pain syndrome. The authors stated in the title of their paper that this was a randomized double-blind placebo-controlled trial, and they found that dry needling treatment was effective in relieving the pain and improving the quality of life in patients with MPS, or myofascial pain syndrome. The problem was that they used a sham needling procedure which may or may not provide enough information to be a true double-blind controlled study. But nevertheless, dry needling was found to be very effective. Here's another potentially promising paper of dry needling of the lateral pterygoid muscle. As you can see in the table, there's a significant reduction in the visual analog scale for pain, with initial pain reported at an 8.45 and after 6 months after dry needling was only 1.95. So the paper clearly showed that dry needling of the lateral pterygoid muscle leads to a significant reduction in pain, but also, as the chart shows, a significant increase in mouth opening. While this is a very promising paper, unfortunately the researchers did not include a control group, which makes it a little bit harder to actually draw meaningful conclusions from this paper. Lastly, Kitris and colleagues published a paper on the effectiveness of dry needling for upper quadrant myofascial pain in the Journal of Orthopedic Sports Physical Therapy in 2013. Based on the best available evidence, they recommended a grade A level of evidence, and they recommended dry needling compared to sham or placebo for decreasing pain immediately after treatment and at 4 weeks in patients with upper quadrant myofascial pain. They did acknowledge that additional well-designed studies are needed to support this recommendation because of the very small number of high-quality randomized controlled trials. This paper did get criticized quite heavily on the internet, but nevertheless, it went through peer review, and while it's not a perfect paper, it does show that dry needling appears to be effective. And with that, we've come once again to the end of this presentation. I hope we've taken you a little bit further to the middle of nowhere, and we hope that by now it is actually becoming somewhere.